Hello, everyone. I'm Jessica Goldstein, Education Program Coordinator at ASRM. Before beginning the webinar, I'd like to go over a few housekeeping items. To make sure we can cover all the content in the allotted time, everyone's line except the speakers will be muted. We'll devote about 15 minutes at the end of the presentation to questions. Please feel free to type a question in the chat window at any time. We'll then read as many selected questions as possible to the presenters during the allotted question and answer time. If for some reason you need to step away from the presentation, please sign out and sign back in on your return. A recording of this webinar will be archived on the ASRM website in the coming weeks. Please watch your email for notification. To introduce our speakers today, I'll turn things over to Professor Judith Dar. Professor Dar.
And welcome to everybody who's on the line. Whatever time zone you're in, we're delighted to have you here. And we welcome you to the third in our quarterly series of webinars being presented by the ASRM Ethics Committee. As Jessica said, I'm Judy Dar. I'm the chair of the ASRM Ethics Committee, as well as a law professor and clinical professor of medicine in Southern California. Today's topic, dilemmas in embryo disposition, has vexed our field of reproductive medicine since its modern inception. Stakeholders in our field are well aware that when gametes and embryos are outside the body, they can be the subject of dispute, of mishaps, of abandonment, and these are all problematic for all of the stakeholders in our field. We're so fortunate to have three speakers today who bring a wealth of experience and wisdom to this arena, hailing from three separate disciplines that all converge along the lines of this problem of dilemmas in embryo disposition. So let me introduce the speakers and give you a bit about their background, and I'll introduce them in the order in which they're going to present today. So our first speaker is Dr. Mark Sauer, and his topic is clinical perspectives on embryo and gamete disposition. Dr. Sauer is the vice chair of the Department of Obstetrics and Gynecology and is the professor-in-chief of the Division of Reproductive Endocrinology and Infertility at Columbia University in New York. Mark has published extensively on topics that are on the cutting edge of our field, making him a national leader in reproductive medicine. And I'm very proud to say that Mark is a current and highly productive member of the ASRM Ethics Committee. Next, we'll hear from Professor Susan Crocken, and her topic will be embryo law, past, present, and future disposition issues. Professor Crocken is the founder of one of the first legal practices in the United States devoted to legal aspects of ART. She's currently a professor and she teaches courses in ART law, including one in cross-border reproductive care at Georgetown University Law Center, where she's also a scholar at the Law Center's O'Neill Institute for National and Global Health. She enjoys an appointment as an affiliate faculty in residence at Georgetown's prestigious Kennedy Institute of Ethics. And she's been so instrumental in merging the legal and medical aspects of our field, being a founding member of the Legal Professionals Group within ASRM and the American Academy of Reproductive Art Attorneys, or ARTA. Welcome to Susan. And then finally, we have Dr. Andrea Braverman, who is going to speak to us about mental health considerations in embryo disposition. So Dr. Braverman is a health psychologist who holds appointment as a clinical associate professor with a joint appointment in the Department of Obstetrics and Gynecology and Psychiatry and Behavioral Medicine at Thomas Jefferson University in Philadelphia. Dr. Braverman is the Associate Director for the Educational Core for OBGYN. She is a highly respected and highly productive clinician and scholar whose work has focused on investigating the psychological aspects of infertility, including first-party and third-party ART. So welcome to all of our speakers, and of course, welcome to you. We're just delighted to proceed. And Jessica's taking care of most of my housekeeping matters, but let me just mention three, and then I'll turn it over to Dr. Sauer. First, each presenter will speak for approximately 12 to 15 minutes with slides. Everybody has slides today. And so you will anticipate a change from one speaker to the next at approximately that number of minutes. As Jessica said, we welcome questions. We typically get a number of questions and are delighted to answer them. And we do so at the conclusion of the presentation. So you can type a question into the chat window that appears at the bottom of your gray toolbar at any time. And Jessica will collect the questions and then she'll address them as appropriate at the end of the presentation. And third, I'd like to take the opportunity to let you know about our next webinar, which we already have established on June 16th. So if you can mark your calendars, we're going to be presenting on the topic of cross-border reproductive care, and we have 3 terrific speakers lined up for that. So welcome everyone, and I'm delighted now to turn over the program to Dr. Sauer.
So thank you. I'm going to speak on issues are related to the clinical dilemmas we face as practitioners related to embryo disposition. I have nothing to disclose. The learning objectives of my talk are the following. At the conclusion, I would hope that you can identify the wide scope of possible embryo dispositions that follow assisted reproduction. We'll discuss the essential elements of informed consent that need to be in place prior to creating embryos. We'll summarize the standard of practice for addressing embryo disposition, and lastly, we'll describe the ethical challenges posed by embryos created through modern assisted reproduction. So first of all, this problem of what to do with embryos is really not a new one. It has plagued our field since the very beginning. The first sensational case occurred in 1983 involving an American couple that died in a plane crash in Chile while vacationing, and they had previously undergone IVF in Australia in 1981, and actually prior to embryos that had been frozen ever resulting in a birth, they had actually cryopreserved 2 embryos, and the estate granted the dispositional authority of their embryos to a minor heir from the wife's first marriage. So it became issue of property law versus whether the embryos actually had personhood status. That was one of the first mentions of personhood that I could actually find. Embryos might therefore have a claim to the Rios, the couple that died, their wealthy estate, which again posed a lot of interesting legal questions. Since the embryos are in Australia, a scholarly committee was convened to try to decide what to do with these embryos, and they actually initially recommended that the embryos be destroyed. But a Victorian court then rejected this opinion and actually awarded custody embryos to anonymous local recipients for their personal use. It's not clear exactly who got the embryos or the circumstances, but supposedly these embryos were transplanted and did not result in a pregnancy, and that rendered these legal issues for the time moot. But it caused an international uproar, and in 1985, just shortly thereafter, in the New England Journal of Medicine, a special report was written by 2 University of California, San Diego professors relating to what do we do with these challenging issues related to this new cryobiology. And it was an interesting article for those that like the history of these kind of things to look at. The focus of it was on ethics and the social issues raised by cryobiology. There was concerns about safety. It was a new method after all. This question again of personhood came up, and the definition of and addressing the moral status of embryos. Whether or not supernumerary embryos created should even be used for research. And there were statements regarding concerns over public policy, or really lack of public policy, that was in place to address these cryogenic issues. So the authors in that article recommended that embryo freezing be limited to only the initial purpose of the intended parent, and that would be for reproduction. Embryos transferred to another woman should only be done with the consent of the original donor, and that under the guidance of a local institutional review board or hospital ethics committee to oversee its proper conduct. And that also embryos should only be stored for up to 5 years. They would not allow indefinite storage use, and that this should all be regulated through a public policy. Now, obviously, despite those recommendations 30 years ago, nothing happened along those lines, and these unique challenges have continued to evolve as our specialties evolved, and a lot has obviously changed. But the basic issues are still there and still troubling an awful lot of people, both inside and outside of our field of medicine. And they relate not just nowadays to the disposition of the supernumerary embryo that are cryopreserved, but also the fresh embryos themselves, since we are culturing embryos now out to the pre-implantation status, and we're seeing a lot more about the biology than we knew existed some 30 years ago. So we're dealing now with both fresh and frozen embryos. We're dealing with dispositional issues related to the genetically profiled embryos that result from both PGS and PGD, and also the dispositions of so-called abandoned embryos, embryos that don't necessarily have a dispositional authority. How big is the problem? Well, it's, again, not an easy thing to answer because people don't necessarily keep a running tally of how many embryos are being stored, and it's not reported to SART. But estimates are likely in the range of around 2 to 5 million embryos just in the United States alone. And this inventory is obviously continuing to grow somewhat exponentially as IVF continues to grow throughout the country. On top of that, there's a shifting paradigm towards biopsy, freezing, and screening using PGS. In our own program at Columbia, the inventory that I think is, again, reflective of the national dilemma shows that we have approximately 6,700 embryos in cryostorage today. And in addition, now we have 1,500 eggs in cryostorage. So obviously more embryos and eggs than any number of uteruses that we could put this material into. So these dispositional issues are obviously very important to define and be able to act on ethically. There's essential elements of informed consent involved in this. The consent of all known gamete contributors or the intended parents is requisite. This would be done preferably as a written and a witness consent. The consenting parties initial each page of the consent if there are multiple pages. That's not always done, and a lot of these consents are rather lengthy. And as Susan, I think, is going to talk about later, take on more and more the look of a contract rather than a consent, especially with respect to dispositional authority. So it's important to make sure that every page was actually read and witnessed by both parties if there are two parties. There should be capacity for informed consent decision making. This should not be done in minors without ability to execute informed consent, or someone who's disabled and lacking capacity. Parental rights and duties under local law need to be stated clearly. There should be an advance directive regarding the disposition of the eggs or embryos that are being stored. There should be a definition for what constitutes abandonment, and that should really be agreed to up front. It might be preferable rather than use the abandonment term to rather spell out as a disposition that after a certain number of years, if no contact is made, we agree to have embryos discarded, for example. Defined authority of the program over this disposition and whether or not and when to discard, because it's really an agreement between the parties, not just the couple, but also the program itself and its doctors. And then there should be some mention of storage and the cost. Because if a patient is storing material over many, many years, this can become quite costly, and you don't want to have a later dispute over money and embryos if you can avoid it. In terms of standard of practice, This is the typical metric for what we use at Columbia University, where I practice, relating to what choices do I have. You can preserve in cryostorage the material, annually renewing the choices and paying the fees of the intended by the intended patients or parents. The embryos could be discarded at any point by the under the authority of these agreements by the patient. The patients can donate the embryos to be used in research, either conventional research that does not include stem cell therapy or research, or specifically for stem cell research. And as I'll mention later, there is a separate ethics document relating to stem cell research. It is different than conventional research. Patients should have the right and the authority to go either or in these kind of types of donations. The embryos can be donated to the program for use by another anonymous intended parent, or it can be directed for reproductive use by a known intended parent in cases where the patient has someone in mind that they believe will benefit from such a gift. As I mentioned, dispositional choices related to stem cell therapy are a little bit more unique than just generic research. This is because of the immortalized nature of cell lines. And so you'd want to, again, assure that the patient agrees to that specific use. In addition, there's possible genetic identification, even though material is typically de-identified. The donating parents or donating patients, I'm sorry, means could be later identified, and that could create a problem. Donation should occur after patients' infertility needs are met or after the treatment has been discontinued. In our program, we always maintain embryos storage for at least 6 months after these types of consents are executed, just in the event that the patient may change their mind. Embryos conceived through gamete donation should have the specific use for stem cells by the gamete donors themselves at the time of consent. There will be occasional gamete egg donors that do not want their eggs later used for stem cell therapy, and we believe those requests should be respected. Donating patients cannot be incentivized or financially profit from donating the material to the program. What constitutes abandonment? It's an interesting problem. It probably represents at least 5 to 7% of stored embryos in U.S. facilities. Some projections are as high as 15%. The consent form should specifically define what abandonment time period is, or what it represents. It will vary among programs. I've seen programs even after 1 year of loss of contact consider it to be abandoned, others 5 years, others 10 years. So it really is up to the institution or to the individual practice. Patients lost to follow-up and cannot be reasonably reached through this defined passage of time without any reasonable contact, and that would be phone calls, registered mail, emails, something that beyond just we didn't hear from them, to prove that you really did try to get a dispositional answer from the patients and failed to do so. Abandonment can also be patients that refuse payment for their storage and reject moving them. It's a little more contentious when that happens, but patients do consent to pay for storage in the beginning, so they are held to that commitment. And patients who affirmatively refuse to engage in any type of decision-making over disposition causes problems, so that in those cases too, you don't have an obligation to maintain these embryos in storage indefinitely, and you may act upon that as well. The patients that refuse to engage in decision-making over disposition create problems for the program because you do not have to store embryos indefinitely. These issues are probably best addressed up front when embryos are cryopreserved in the more affirmative sense of, in the event that you are unable to make decisions over certain periods of time, in the event that you are not paying for storage over a certain period of time, then we agree that these embryos may be discarded or may be used for research or whichever the advance directive. It puts the information up front with a resolution to the problem, as opposed to a more reactive stance by the program later when patients believe that the program believes that patients have actually abandoned the embryos. There should be a defined policy for how to discard and dispose of the embryos. Embryos are typically handled as biological tissue without special status, and they're therefore disposed under local Department of Health and CLIA guidelines as biological waste. Biological waste is managed under specific Department of Health guidelines and regulations, which are oftentimes not very flexible, and patients have sometimes a difficult time understanding that, because they may have a different view of the status of the embryo than the health service. Patients occasionally request that these embryos therefore be returned to them in order to personally manage their final disposition, and I've had patients request them being returned for their private burial or for what has been termed compassionate transfer, where embryos are placed into either the patient's vagina or into an intended parent's uterus at a time in the cycle when they know that implantation will not occur. There are programs that will accommodate these types of requests, but again, they should be defined by the program and the patient's individual consents. You want to avoid conflict. That's what these consents are really all about. Intended parent or parents can disagree on dispositional directives, as a recent court case in California between a divorcing party where the husband no longer wanted these embryos for reproductive purposes. His ex-wife asked that the court grant custody to her for reproductive use, and the court followed the consents, the disposition of the consents, which said in the event of our marriage dissolution, the embryos would be discarded, and that's the way it was handled by the court in California. Conflicts can occur between intended parents. Conflicts can occur between parents and program over what to do with embryos. And conflicts can occur between parents and a third-party donor if the donor is known. So all the parties that are known, as I mentioned earlier, and the program need to be on the same page going into these cycles to try to minimize these types of conflicts and to hopefully end with a resolution that everyone agrees with. There can be demand for transfer of embryos that have been determined to be abnormal. In the more conventional sense, abnormal could be slow or abnormal cleavage stage in development, or poor embryo quality, such as embryos lacking in inner cell mass at the blastocyst stage of development. They could be deemed abnormal as determined by pre-implantation genetic screening, abnormal karyotypes such as trisomy 21 or mosaic embryos. And they could be abnormal by the genotype in PGD cases where recessive or even dominant traits have been determined to exist, and patients may still request that these embryos be transferred. A recent study in the New England Journal that was published is illustrative of this problem. This biopsies on 18 women who had no normal euploid embryos, just mosaic embryos, were allowed to be transferred, and interestingly 6 euploid babies delivered following the transfer of these mosaic embryos. So knowing that complex mosaic embryos may be seen in up to approximately 5% of PGS cycles, you can anticipate the problem, because there will be patients that are going to ask that these types of embryos be transferred, and it'll be up to the programs to decide if they are willing or not to do that. Other type of case study with the BRCA positive patients, we've seen this happen now a few times where couples coming in to try to minimize or avoid transmission of BRCA to their offspring only produce BRCA positive embryos. And in the case that we had recently where both 46XX and 46XY embryos were produced, the couple did desire to use the BRCA embryos. And in this particular case, they chose to transfer the male embryo, which delivered, and he was genotyped, and as we expected, he was BRCA positive. This is an interesting dilemma in the sense that BRCA phenotypically is not always expressed, and so you can carry abnormal genotypes and still be perfectly healthy and live a perfectly healthy life. So it's not totally black and white as to what patients ought to do under these circumstances. Another case we had recently that went to court, a single woman with only morphologically abnormal embryos, is these embryos were not karyotyped. They were just morphologically abnormal at the time of their disposition. And what she had on day 6 were basically no normal blastocysts, and in fact, the only blastocyst that she had clearly no inner cell mass. So she had been told that we would discard these embryos and refused and wanted the embryos transferred to her. Our program ended up cryopreserving them because we didn't feel comfortable putting abnormal embryos into patients. She demanded a second opinion, went to court to force an embryo transfer, got a court order to that effect, but the embryos, again, being in cryo storage at that point, just led to an issue of disposition. And it kind of represented the typical conflict of patient autonomy versus medical determinism. But the way it was settled was that they were transferred to a long-term storage facility for later use, where they still are sitting, and the patient will find another program perhaps that is willing to accommodate her request. So in summary, in terms of recommendations, the management of embryo disposition is complex, and it is best defined and agreed to by all parties in advance of the treatment. The advance directives should be included in the treatment consents, and this should include clauses related to the dissolution of marriage, the death or incapacitation of any consented intended parent, issues of abandonment and dispositional authority, including the rights of the program to dispose of embryos, should all be in those consents. Dispositional authority may require judicial review, as I illustrated to you today, to determine the final disposition. And everyone should keep in mind that patients' lives and advance directives may and often do change over time, and it's important to review and renew these consents and directives annually.
First of all, I want to thank ASRM for the opportunity. I think this is an important topic, and I appreciate the invitation to participate. And I also want to thank all of you for your time in joining us this evening. I have nothing to disclose, and my learning objectives, I think, are clear. I always like to start by making it clear that I think there are 3 unique features of the arts that impact the way the law approaches this area of embryo law. First of all, fertilization takes place outside the womb instead of inside a woman's body. Secondly, we cryopreserve sperm, eggs, embryos, and ovarian tissue increasingly. And third parties are involved, exponentially complicating the rights and obligations, both parental and non-parental status, and of course raises a lot of very important dispositional questions. So let's start with what is an embryo. Is it property or persons? I would suggest neither. Is it something in between? Yes. The courts have become increasingly clear on that, I believe. There's also an important distinction between fertilization and conception. Conception is an old term that long predates IVF. It's much more accurate in the context of IVF embryos to talk about fertilization by sperm of eggs. It is a process, and what you gain from doing that is it's more scientifically accurate and less susceptible, no pun intended, to being manipulated as your life begins at conception. Divorcing embryos is a topic I want to talk about in terms of the case law, the court decisions in that area, and then I want to spend some time talking about whether or not these abandoned embryos that worry everyone are, in many cases, abandoned or not, and what we do about them. So, pre-implantation IVF embryos, from a legal perspective, there is no single consensus definition. Context and jurisdiction always matters. By jurisdiction, I mean the state in which the case is decided and the state law under which it is decided. The very first frozen embryo divorce case was in 1992, the now famous Davis versus Davis case, in which that court actually relied on ASRM Ethics Committee's definition. It was then the American Fertility Society, and said, we conclude that pre-embryos are not, strictly speaking, either persons or property, but occupy an interim category entitling them to special respect because of their potential for human life. And I emphasize pre-embryos because the courts have been very willing to look at scientific evidence and to distinguish developmental stages under whatever name is given to them and they're chosen. And special respect because of their potential, but not because of their existing human life. The court in that case decided that in the absence of an agreement, and the IVF clinic had moved to not unpack their forms, unfortunately, there were two constitutional rights to balance, the husband's right not to procreate and the wife's to procreate. In this case, they said in the absence of a prior agreement, his right not to procreate trumped, and the embryos needed to be discarded as he wished. There have been since 1992 over 20 court cases in a myriad of states that have looked at these questions. Invariably, as I mentioned before, the courts are willing and happy to have scientific testimony with medical experts testifying about developmental stages under various terms. If any of you have the opportunity to educate a court, I hope you will accept it. The facts, the theories, and the outcomes have all varied. The courts have just looked at whether or not they should use a contract theory, a change of mind theory, a contemporaneous consent theory. But the bottom line is that until very recently, no court had ever allowed one former spouse to use them for procreation over the objection of the ex-spouse. In the last 3 or 4 years, we have seen a rash of lower court cases looking at this issue once again, what I call last chance divorcing embryos. And understandably, these cases come up in the context often of women who are cancer survivors and do not have another opportunity to be a biological parent. If you think about it, it makes sense because who would spend time and money in court if they could just create new embryos? So I'm not going to go through each of these cases. I would emphasize they're lower court cases, which means that they do not have precedent outside of their own area, even in their own state, but they are interesting. And so in Pennsylvania, the court said give them to the wife. It didn't have help that her husband was fertile, had an affair, and another child with another woman. In Maryland, the agreement had been to give them to the wife, and the court said do it. Dunstan is now up on appeal, which is a very interesting, unique case in which an unmarried woman had a relationship with a much younger man. Her boyfriend had offered to be a dad or a donor. In other words, if we break up, you can still use embryos created from my sperm. The court found that intent was consistent, if not adequate, in the consent forms themselves or the documents from the IVF clinic in oral testimony. And even though he later objected because his new girlfriend didn't want him to, the court said, you know what, you promised to be a donor, you are one. Findley versus Lee, we'll talk about a little bit more in a minute, is a case out of California in which the agreement had been to discard, and even though this was an oncofertility case creating embryos under very quick time constraints, the court said everyone knew what they were getting and the agreement needed to stand. There is an appeal in Missouri going on with respect to this same issue. There is a group called the Embryo Defense League that has come in to help the ex-wife, and of course the Loeb versus Sophia Vergara case is pending. They had an agreement that they could not use the embryos without mutual consent. Loeb is calling them his female children and seeking custody, again showing you the dangers of this conception argument. I don't mean to suggest that the doctors in court on Tuesdays and Thursdays, I know you have other important things to do. What I am trying to do is point out some of the legal shoals, if you will, that you can hit if you're not aware of them and what you might be able to do to avoid them. So let's take a quick look at the Findley versus Lee case. The IVF was performed 10 days after the wife's cancer diagnosis, creating 5 embryos. It became critically important to the court what the documents the clinic provided the couple looked like and what they signed. And this is where some advice is going to come in. The first document the court said was an informed consent for the IVF treatment. The second, however, which was critical, was called a consent and agreement for cryopreservation and disposition of frozen embryos, and the couple chose discard. The wife changes her mind, as in all these cases we've seen, and the husband wants to live up to their agreement to discard. So the question before the court was, is that second document an informed consent or a contract? Why and how it matters is what's important for our conversation this afternoon. The IVF program was joined as an indispensable party. The IVF doctor ended up testifying for 6 hours. On cross-examination, one of the hard questions he got was, do you kill embryos, doctor? His position in that of the clinic was that this was a legal agreement binding between the clinic and the patients, and otherwise there would be chaos for the thousands of IVF patients who come through. The court decided in favor of the husband and the clinic that it was, in fact, a contract. This will always have a state law component, although there are general principles of contract law raised here. A contract, unlike an informed consent, has to show an exchange of value. In exchange for this, I give you that. It needs to be signed by all the parties. It needs to be clear that everyone understood and had time to reflect. In that regard, I would suggest to you that when you're dealing with oncofertility patients, this can be a vulnerable point and you want to document carefully. The court asked whether the couple had an opportunity to consult attorneys and make changes if they want. And at the end of all of that, concluded that, in fact, it was a legal agreement, it was binding, and the wife had signed on to having those embryos discarded and must keep to that promise. So beyond Findley, what I think is going to happen is that we're going to continue to have these debates. In my own world, people are talking about, my colleagues, whether there should be a private agreement between a husband and a wife. I think that could be a very good idea, but I also am not sure it's a practical one because the patients keep coming and they don't believe they're going to be in that 50% of couples in the United States who divorce. So what can you do in the interim? I think you need to do what the clinic did in Findley, which was UCSF. They create separate documents, a very clear agreement. It may also include consent language, but it has to meet the contract principles for storage and disposition. Our START model consents are a good starting point, but we have begun to update them because I think these issues are becoming clear most recently. And even if you look to general principles, which I think are there, you should also make sure you comply with state law. California, for example, had specific criteria. New York allows donors to withdraw. You need to have somebody check these for local compliance. There are advances that are going to change this issue. Short-term storage probably is going to become more and more prevalent as people move embryos off to long-term storage banks. However, you're still going to hold those embryos for some period of time. You're going to transport those embryos to another location, and therefore you're going to still need these types of documents. You also have to deal with your older embryos, so let's spend a few minutes on what I consider a question. Everyone talks a lot about the worry of embryos being abandoned and what to do with them. I think the very first question that you need to ask is, are the embryos actually abandoned? The only way you can answer that question is to look at the forms and letters that accompany those embryos. And if you're like most of my clients, your program has made changes over the years, so you need to match up the embryos with the documentation. If your document says, if after X number of years we have not been able to reach you or heard from you, you authorize us to discard them, I suggest to you those are not abandoned embryos. Those are embryos with discard instructions, and you should consider whether you should follow them. Also check ASRM guidelines because they suggest protocols and they help define what is and isn't abandonment. To my knowledge, there's very little state law on this, but it should also be checked. But the biggest caution that I would give you is don't unintentionally trigger an abandonment standard. By that I mean, I've seen well-meaning programs that go back into a set of embryos and had clear instructions and instead send a letter that says, we haven't heard from you in 17 years, and therefore, if we don't hear from you in the next 90 days, we will consider you have abandoned your embryos. I would suggest to you that instead of helping the program, what they have done is they have triggered an abandonment standard, potentially another 5-year period. So my hard advice is say what you do and do what you say. I know these aren't easy choices, but I think there are some potentially very tough consequences if you're holding embryos with instructions to discard and you don't. Consider for a minute a woman who comes back to you 15 years later and says, do you by any chance have them? And you say, as many programs I think would, yes, although you told us to discard them, we weren't comfortable doing it, so we have them. She says, great, I want them now. Her ex-husband, who's moved on, has another family. The last thing he wants is another child to support or to have born. will say, wait a minute, we told you to discard those. Why didn't you do it? I think a program that has failed to follow those instructions is very vulnerable to the ex-husband's claims. So a crystal ball, no, but some suggestions, yes. Current embryo dispositional challenges, develop a protocol with legal advice and follow it. For the older embryos, check what your protocol was and follow it. I think ESET is going to have an impact on embryo freezing. We're going to have more frozen embryos as a result, and we're going to have to make sure our documentation and the counseling around it is there. With respect to same-sex couples, I think they may be highlighting the issue of donor-created embryos, and I think we're going to have to face that square on. It's not different for same-sex couples. It's just that they, in every instance, will have one donor gamete, and we have to look at whether or not that changes the balance between the intended parents. Egg freezing is also a new development that may eventually replace embryo freezing, and if it does, it will eliminate many of these questions going forward. It also may remove the basis for the anti-abortion personhood battles I mentioned at the very beginning, because we won't be struggling with this question of conception and when does life begin. Egg freezing, I'm not going to spend a lot of time on this. I'll just suggest to you that it both is practicing safer art with respect to embryos, but it may create new problems. It will likely reduce embryo dispute, but it is going to also require you to counsel your patients much more carefully around which they want to do, what are their vulnerabilities, time constraints. You're also dealing with multiple specialties, oncologists who want to get going, and clearly you need to document carefully. The second target population are those who are doing what are considered social and elective freezing, and as you're well aware, there's a lot of marketing, and I think there's a potential liability there about over-promising, because as in all areas of this field, advances happen quickly, and women who are in their 20s who are suggested to freeze may find that 5 years from now, while their fertility is still quite good, they don't need them, but they've spent a lot of money. So I just caution people not to overpromise. I often suggest that, my law students think this is a great idea, freeze your eggs and free your career, but I would caution you to keep in mind that 10 years from now, they're going to be lawyers with all the tools of the trade if what you promised them doesn't pan out. So be careful there as well. They are tomorrow's lawyers. So in closing, I just want to suggest a couple of take-home messages. Language is critical for the law. Special respect for pre-implantation IVF embryos, I think, is where you want to land with respect to thinking about embryos. Neither persons nor property, but entitled to that special respect. Always document what you do. I would recommend highly using both informed consents for the process and contracts for the embryos. I think it's going to be helpful even if the law is unsettled. I think we need to be aware, particularly of donor-created embryos, changes of mind, and issues around onco-fertility for documentation. Frozen embryos, be careful, don't make them abandoned if they're not. Egg freezing is going to help but raise new issues. And lastly, don't shoot all the lawyers.
Well, it is a pleasure to be invited to speak about mental health considerations in embryo disposition, and it is my hope that we can give a little bit of some thought to what mental health issues do come up, and sort of in the context of what's been happening in the world of embryo freezing. So the learning objectives are fairly self-evident. We do want to talk about the role of the mental health professional. We want to look at the issues that contribute to influence people's feelings and attitudes about their embryos, and then we're going to talk about the choices and how all of these different factors come together with their disposition choices. So, as you've already heard from Mark Sauer and Susan Kraken, there are the following embryo dispositions. You can use the embryos for yourself, you can thaw and discard, you can donate for research or training, which is ultimately a discard option, you can donate for reproductive purposes, or you can basically avoid the whole thing and just indefinitely pay fees. You certainly would like to avoid willing your embryos to children. As I tell my patients, that one's a fairly universal yuck kind of reaction to it. But, there's a limit to how much you can kick the can down the road, and yet we see people doing that all the time. In terms of the context for attitudes and feelings about embryo donation, I mean, really what we need to appreciate is that these attitudes and feelings aren't done in isolation. They emerge from a whole myriad of different issues and reasons and influences, and certainly culture is a big factor in terms of how people contextualize their attitudes and feelings. Religion is probably the clearest one that people understand, but it may also be just developmental, where in the IVF or the infertility process they are. And I think we are all familiar with patients who say to us, you know, look, I should have such a problem down the road, I'll deal with it then. They give cursory regard to the disposition considerations when looking at the consent forms because it's not real. Or it may just be they're too early on. You know, if they're a seasoned veteran, they come to it from a different perspective. Certainly, partners' feelings and beliefs feed into one's own attitudes and feelings about embryo donation, and then there are the ones we sit with ourselves. And as you can see from the pictures below, you know, when we say an embryo, for some of our patients, they're picturing the beautiful baby in the basket, and for others, it's a very scientific approach. It's a pre-embryo, it's a group of cells. So there is not one single attitude or feeling about what frozen embryos or their disposition mean to anyone. It's really helpful to take a look and see what the research says about this. And Lyerly in 2010 did a very nice study and looked at a little over 1,000 patients with cryopreserved embryos. Sorry, I was trying to get to something and did not succeed with that. So they looked at these fertility patients with cryopreserved embryos, and what they found was pretty much what I think we feel clinically. 54% were very likely to use for a reproductive purpose, 21% were very likely to donate for research, 7% or fewer chose other options, and those who gave high importance to health and well-being to their embryos were more likely to thaw and discard or freeze indefinitely. But we also see a lot of literature talking about this delaying decisions. And in this 2000 study, they found as many as 70% would delay making a decision for a long time. And in the 2005, some would just delay indefinitely. So that's the kicking down the can down the road and just hoping that it's not going to have to be dealt with. What are the beliefs about frozen embryos, and what do we see from other research? Well, in this other study, what we found were the beliefs, fears, and doubts about the effectiveness of treatment with cryopreserved embryos certainly encompass misconceptions about them. And I think we're going to hear that theme emerge, which is that despite the fact of our best efforts to educate and inform, our patients are not always as well informed as we think, and there are certainly misconceptions that occur. Many patients also feel that this is rarely discussed with medical providers, and we're going to see this in a very recent study in a little bit. Lyerly, again in 2006, had done a very nice study looking at the patient's decisions about embryo disposition and found these 7 broad themes about their participants' decisions about what to do with their embryos. And what we saw was that what emerged were family and personal issues, trust, definition of the embryo, interestingly, the prospective responsibility to the embryo, responsibility to society, the adequacy of information received, and the lack of acceptable disposition options. So, in terms of do preferences change over time, I think anybody who has worked with couples and have talked to them at one point of time and then further down the road after they have children, it's not surprising to see in the literature that preferences change over time. And Chris Newton's 2007 study, he and his colleagues found that more than a third of patients had not returned for frozen embryos by 5 years, and 31% of those declined to provide an updated directive. Those who had a live birth through treatment were more likely to provide a new directive, more likely to choose to discard rather than donate embryos for research. In other words, we see now feelings are changing based on circumstances, and obviously a big influential factor is whether or not they had a baby. Prior to IVF in this study, they found the majority of those who did not return elected to donate unused embryos for research, but 59% of all couples overall changed their minds after treatment. So this is a fluid decision, and it is not a one and done type of decision. Conceptualization certainly does change. Noctegal and colleagues found in 2005 that with an average of 7.1 embryos per couple, and after an average of a little over 4 years of storage, almost 3/4 of couples with frozen embryos had not reached a disposition decision. Most had not anticipated or appreciated the consequences of having these extra embryos. Now remember, this is despite all of the attempts at education. Interestingly, in this study, we hear some of the similar themes. They conceptualize their frozen embryos as biologic tissue, some as living entities, some as virtual children having interests that must be considered and protected, or siblings of their living children, genetic or psychological insurance policies, the so-called spare, and symbolic reminders of their past infertility. So some of these may be positive, symbolic reminders of their past infertility is more burden than blessing, as they say. So are we adequately educating our patients? Well, in this Canadian study, just published in Fertility and Sterility, they looked at 131 Canadian couples with embryos cryopreserved for more than 2 years. And what they found was that 64% of these couples reported spending less than 1 hour contemplating their wishes for what to do with these embryos before initiating the IVF treatment cycle. 3/4 reported the final decision regarding embryo disposition to be a challenge. This is not a simple decision. And yet, when we find them at the point of time, as we were looking at earlier, prior to actually creating embryos, prior to hopefully having a live child from this, the question is, how real are these decisions to people? And in a sense, do we go from the intellectual to the real? And all of these things lead to huge influences on thoughts and feelings and sense of responsibility. In this study, they also, you can see in the highlighted box, they asked, was the treatment adequate? And what we're finding is that out of 131, 55 said no, they didn't feel that that 55 said after treatment was the education provided adequate or excellent. It's complicated. Was it good before? Was it good after? We say, well, it was better before than after, and what does that mean? And we'll take a look at putting that all together in a minute. So how does the mental health professional come into this? So if it's a moving target, if people's thoughts and feelings are evolving as they go through the process, as they're going through treatment, as they're having children, where does the mental health professional come in? Well, I would argue historically mental health professionals were very involved in the discussion of embryo disposition because in the past we were preparing patients for this long road for in vitro fertilization. Success rates were lower, average number of cycles were greater rather than fewer now, and so as we see the number of cycles to conceive is fewer, we sort of have the speed up of the IVF process. I would argue in that, not that there was any intentional part of this, but I think as we became better at it, the idea of really looking at disposition options for these frozen embryos became less focused because we looked at the overall treatment of the burden of treatment to be less overall. And so as we got faster, this sort of became almost, it gets put in the parking lot a little bit more. As we've also heard, single embryo transfer is increasing, and ironically, as we've gotten better, it also means that we might have an increasing number of parents who have cryopreserved embryos, or as we've also heard, and as Susan Crocken was discussing, if we're, the implications of pre-implantation genetic diagnosis or screening also means that we are freezing embryos more and more, and that may mean also this may be more of a reality of a decision to intended parents than it was before. The other thing is, as we know, unfortunately, the number of couples who divorce or separate needs to be substantial. So the issue around disposition of embryos with intended parents who initially started off to have this child together and now don't, that also may be increasing. You know, the question is, as we were looking at Lyerly's 7 themes, would this be appropriate to be addressed as part of the psychoeducational process? Is there thought to saying, let's go back, reassemble how we approach talking about cryopreservation with patients, and really bringing the full respect and weight of this decision-making back and reflecting it back to our patients? Should we be talking to them and saying, look, here are 7 broad themes that people think about when freezing their embryos. Maybe this is something that you want to go home and discuss on all of these different issues where you feel individually and as a couple. Certainly, Newton's research suggests that a very good model in which counseling is done twice, both before and then after, would be appropriate. Look, I understand that in the busy practice world, the reality is there's not extra time to do all these things. And yet, what we hear, and we've heard from Dr. Sauer and from Susan Crocken, is that we do see these cases coming back, because if we don't spend the time talking and counseling appropriately, then we can see our patients getting into not only into disputes between themselves, but even between themselves and the IVF facility. So perhaps if we normalize this, we're going to talk to you both before freezing and then after, and we will be following up, either after the baby is born or 6 months after creating, just starting to put in those markers. Look, ideally, this would be the purview of the mental health professional. I will always advocate for full employment for mental health professionals. And I think that we are very skilled and a very appropriate member of the team to do this. However, it's not always practical. Not every physician and team has a mental health professional either on staff or easily available to them in the program, in which case then I think IVF clinics need to think about who might be the appropriate person on the team in addition to the physician to do follow-up. I mean, look, having the physician do follow-up is a great idea, but again, may not be a practical solution. So, let's start thinking creatively and broadly about how to meet these patient needs. And so one of the questions is, could we have a self-guided study? Is there information that we should be developing that would be helpful to give to patients? And obviously not self-guided study, but are there talking points? Are there things that we should be doing? Is it in written format? Is it video? Is it all different ways to approach this? Do we need to also be throwing in the discussion of posthumous reproduction? We certainly have not touched on that a lot in terms of frozen embryos, but again, when we talk about disposition options, then we should be also asking if the proverbial, God forbid, something happens to either or both of you, what does that mean? And maybe we also need to think of a model of front-loading counseling before couples get into disputes. So we see it in both directions. Very famously, we see this with our Hollywood stars, where he wants, she doesn't, or the other is she wants, he doesn't. And we need to be able to make sure we are addressing this adequately, because certainly when we see them, if you're trying to make a baby together, the first thing you're not thinking is, hey, well, if we split up, what are we going to do? But if we normalize this and say, look, we're not pointing fingers at you, but we know that this can be a serious issue down the road, let's just put a marker on this and have everybody give a thought to it. Perhaps we can do a better job of front-loading this discussion and this counseling. So I'm going to end with the idea that I think we need to be revisiting cryopreservation counseling. And I think we need these respectful and thoughtful discussions that are already going on, but in a sense we need to put them on steroids and really bulk them up and increase them and really try to do an even better or best job at getting our couples counseled, or individual parents counseled, so that they are really as prepared as they can be for the future, and giving strong consideration that as much as we would like to make this a one point in time discussion, that maybe we need to really rethink and do a follow-up consultation with our individual couples who have their frozen embryos. And with that, I'm going to conclude my slides, and we're going to have our open discussion with the questions and answers. Thank you.
Thank you very much, Dr. Braverman.